Hi, well, good afternoon, everybody. My name is Katherine Ruiz, and I'm a first-year internal medicine resident in Wilmington, North Carolina. Here today, I'm going to be presenting to you a case report of Myroides Odoratimimus bloodstream infection presenting in a male patient with encephalopathy and short-term memory loss. So this is a case of a 65-year-old male with a past medical history of diabetes and heart failure that presented to the ED after being found at home with altered mental status. He was found in the floor covered in human feces, maggots, and flies. He was last seen 4 days ago by his neighbors while he was walking his dog. The last event that he remembered occurred 8 days prior to the admission, and he had no recollection of the events that happened in the last 4 days. Vitals were stable except for moderate hypothermia at 29.8 Celsius. Lab testing showed profound acidosis, rhabdomyolysis, and an acute kidney injury. Upon physical exam, he had retiform purpura with cutaneous necrosis formation over his chest and legs. As you can see in the pictures here, the lesions were mostly in his chest, legs, and knee, but they were present all over his body at a lesser extent. Due to the perplexing skin lesions and his immunocompromised state, the differentials included, but were not limited to vasculitis, invasive mucormycosis, anticoagulation-induced necrosis, fungal sepsis, bacterial sepsis, and an embolic event. Due to concerns of angioinvasion and his presentation, he was started on broad-spectrum antibiotics and started on bicarbonate and IV fluids. The next day, the patient's blood cultures grew Myroides Odoratimimus, and tissue cultures were positive for Enterobacter, Candida parapsilosis, and Staph saprophyticus. The patient was able to recover successfully, but he was never able to remember what happened on those 4 days that he had missing. The importance of this case that I present here is that we have to be aware of every differential and even the diagnosis on given the increased incidence of resistant bacteremias and how we are able to treat them. An infection with a bacteria like this poses a challenge when it comes to treating them because it produces a biofilm that makes it resistant to multiple antibiotics. Fortunately, my patient's sensitivities came back and he was susceptible to ceftriax, to ciprofloxacin, for which he completed a 10-day course. That is all I have for you, and now I can take any questions.
Thank you for the excellent presentation. What was this patient's lab results like? Anything elevated?
I'm sorry?
Were his lab results elevated? Were there anything that was abnormal?
Yes, his white count was elevated. His lactic acid was also elevated. He also had a bandemia with that white count very high in the 60s. And because of that and the moderate hypothermia, infectious diseases was consulted at that moment when he presented, and those were their recommendations. So yes, he had an elevated creatinine, he had an elevated CK because he was found in the floor for 4 days after. It's what we believe that he was down in the floor with a white count and an elevated lactate. Everything else was normal.
And do you know how this patient is doing now?
Yes, he actually was able to recover. He did not remember the events. His injuries right now are recovering still. He's being followed by a dermatologist as well as infectious diseases because he has not been able to grow any skin back on those infections, on those skin lesions that he had. So he's still being followed by a dermatologist for the lesions, and they are still treating him as if it was this bacteremia that caused it, but they are also looking at they have collected more samples and sent it to labs to try and see why he has not been able to recover and grow skin back there.
Wonderful. Thank you so much for your excellent presentation.